Okay, welcome everyone. Trevor Mashak here, and today we're going to take a little bit of time to talk about wound care and how wound care takes place in the wilderness setting. So we see here kind of a pretty graphic representation of what a wound in the wilderness might entail. So this is what looks like a hand that has actually been impaled by, I believe, what is a crankshaft to a mountain bike. So kind of hard to tell exactly what's going on in that picture, but we see that there's actually that mechanical piece of equipment that's still lodged into the person's wrist and into that person's hand. So we can imagine that this poses quite a bit of problems to the patient, both due to the structures that are involved, the vasculature, the nerves, the bones, the joints, all of that that's involved in this injury. But also consider the fact that when we have something like this happen, and just in general when we talk about wounds in the wilderness setting, we're oftentimes talking about objects that are dirty, wounds that are dirty that can become contaminated, and so we have a lot of risk for morbidity down the road should we not take care of these correctly. So as we go through this lecture, we'll talk about the various steps that we should take when we are managing someone with a wound, typically talking about a soft tissue wound, so something to some break in the skin, damage to the adipose tissue, damage to the musculature underneath, and then we'll kind of talk about how this is all affected by the fact that we're in the backcountry setting. So when we talk about goals of wound care, we kind of have these major steps. So the primary goal, our priority anytime someone has a wound, is to stop the bleeding. We'll talk about our methods for stopping bleeding here in a little bit. Following that, we want to make sure that we clean the wound, prevent infection. We're going to dress the wound in some fashion or another. And then lastly, something that oftentimes comes up in this discussion is the consideration for closure. So should we actually close the wound, be it with stitches or sutures, staples, or butterfly steri strips. So we'll kind of talk about the discussion there, and then we're going to finish this up with just a couple of different things that we might run into. So in regards to bleeding control, it's important to recognize that most bleeding can actually be controlled by direct pressure. So what that means is you're going to take a piece of gauze, some kind of bandage, maybe you're improvising with a shirt or a blanket or something along those lines, and you're just putting direct pressure onto that wound. That doesn't mean that you're taking some bulky piece of gauze and laying it on the wound. You're actually putting pressure and causing those blood vessels to become closed. And that will oftentimes be all that it takes to resolve bleeding. Gauze, a gloved hand, a clean t-shirt, all these can be used to control bleeding with simply direct pressure. And again, this is not just taking something absorbent. Oftentimes we are using material that's absorbent, but we're not just allowing that to soak up the blood. We're actually applying direct pressure to promote hemostasis, or the stopping of blood. So oftentimes direct pressure is all that it takes, but after we apply direct pressure, we have to reassess the bleeding, consider a pressure dressing, and then if that doesn't work, we'll have to consider a tourniquet. So when we talk about pressure dressings, this is simply some sort of bandaging that actually applies direct pressure. So you can then remove your hand. You're not having to stand there and use your hand to actually hold the pressure. A pressure dressing creates that pressure on the wound, and sometimes that's enough to stop the bleeding. Now, if that's not enough to stop the bleeding, we're going to have to move to a tourniquet. So tourniquets, we have both commercial tourniquets and improvised tourniquets. We'll practice with both of these in our practical sessions, so you'll become familiar with how to create an improvised tourniquet, but we'll also familiarize you with the various commercial tourniquets that are out there. But it's important to recognize that tourniquets absolutely can be life-saving. In the past, it was commonly worried that the complications of tourniquets were too high, and so we used to have this process by which we would take care of bleeding, and tourniquets would be a very last-ditch effort. It was something that we'd reach for way later in the game, and that's all changed. So due to these studies that have actually come out of the military, which is where a lot of our trauma research comes from, we found that tourniquets actually don't have that high of a complication rate. You can actually put a tourniquet on someone's arm and leave it in place for a number of hours, and that risk of neurovascular damage, of tissue ischemia, and tissue infarction actually isn't as high as we thought it was. So the current recommendation is that if you have any doubt in your mind about controlling that bleeding, especially if it's significant blood loss, if it's some kind of arterial bleed or just a very large laceration that's bleeding quite a bit, by all means reach for the tourniquet early on. The benefit there of stopping the bleeding and preventing blood loss absolutely outweighs the risk. Something that's also important to keep in mind is that sometimes in a wilderness setting, and oftentimes in a tactical environment, we are exposed to dangers, so the scene might not be safe, and so a tourniquet is absolutely an appropriate means to control bleeding temporarily while you move that person out of the hazardous environment. And so what that might mean in the wilderness setting is perhaps we're in a storm where we're exposed to the elements, we're exposed to lightning and rain, something along those lines, or maybe you're in a technical environment, be it a steep or high angle situation. A tourniquet can absolutely be a temporizing measure that you can then reassess down the road as to whether or not they actually require a tourniquet to control that bleeding. Interesting study here out of Baghdad. We have 499 patients that received tourniquets. No loss of limb reported due to tourniquet use. So oftentimes we place the tourniquet on the patient, we tighten it all the way down until the bleeding has stopped. It's important to recognize that that's the purpose of a tourniquet, is to actually cut off arterial blood flow distally to that tourniquet. And then later down the road, as they get into the emergency department, that wound is then reassessed, and then it's managed in the hospital setting, and then they're able to remove that tourniquet. They then are allowing blood flow back to that extremity, and we are seeing that the actual rate of limb loss due to tourniquet use is very, very low. In this study, it was reported that no limbs were lost. Now, it's important to recognize that there still is that risk of neurovascular damage. We do have long-term nerve damage, and there is some tissue damage as well. But in the grand scheme of things, I would rather have a little bit of nerve damage to my extremity rather than bleeding out and going into shock and going into organ failure as a result of that. So again, that's kind of going back to that risk versus benefit scenario. Certainly the benefit of saving someone's life and preventing them from going into decompensated shock is more beneficial, or it's better for the patient's outcome, long-term outcome, than the potential for the damage to the limb or to the nerves and vasculature. So a couple different classifications of wounds. We have incisions and lacerations, which are basically just smooth cuts that break through the skin, that break through those structures that lie underneath. Sometimes the edges are well approximated, or it's a clean laceration, meaning that the edges will actually line up. Sometimes these lacerations aren't caused by a nice clean edge, in which case they can be quite jagged, and there might be some difficulty in closing that down the road. When we assess incisions and lacerations, we're looking at both the length of the incision and laceration, the structures involved. So over on that right-hand side, we see that laceration is actually overlying the hand and the structures in the hand. And so the concern there being that that's an area of movement. We have a lot of movement in the hand because it's a body part of function. And so anytime you have movement, it becomes more complicated when we close it and when we manage it, because those edges might move anytime that the person utilizes their hand. We also want to assess the depth of the laceration. So are we going all the way down through the musculature and to the bone? Is there tendon involvement? So sometimes you can actually see tendons that are also cut underneath the skin. We're just trying to see what kind of structures underneath are involved. Some other things that we see, avulsion. So this is essentially when you have a flap of skin or tissue that's folded over, and sometimes in this case completely removed from the extremity. And then we have abrasions, commonly thought of as road rash, but basically have some kind of friction over your tissue that actually removes skin and removes tissue. When we talk about abrasions, it's important to recognize that just due to the mechanisms of injury that commonly cause this, we do have a high rate of infection due to bacteria and foreign pathogens being embedded into that tissue, and also just the large surface area that's oftentimes involved. The larger the surface area, the higher the likelihood that that wound can become infected down the road. So moving right along, we have punctures, and so this is essentially due to some kind of penetrating object that pokes through our skin and pokes through those underlying structures. So in this case, it might be from a bite, it might be from a stick or a nail or something along those lines, basically creating a small opening that goes deep into the underlying structures. We then also have blisters, which we'll talk about lastly, but basically blisters coming from a number of different mechanisms. In this case, what we actually see is blisters across all fingers. This is due to frostbite injury, so this is commonly what a frostbite might look like down the road after it's developed. We also have burns that cause blisters, commonly blisters caused by friction, so most commonly we have those in our hands and in our feet. You can also have blisters from chemical exposure as well, just to name a few. Okay, so we talked about bleeding control, and again, we'll really practice going through the various types of bleeding control in our practical session. But let's talk about the steps that we have to take after we've controlled bleeding. So our general goals, we first want to assess the wound and see what kind of impact that wound has had on our neurovascular status. And so quite simply, that's going to be checking our pulse, our motor, and our sensory, otherwise known as our PMS, distal to that injury. So if I have a large laceration to my forearm, I'm going to assess that I have circulation, so I'm going to feel for a radial pulse. You can also feel for an ulnar pulse as well. You're going to check for sensation, so seeing that I'm able to feel as I squeeze in the fingertips, and then you're also going to assess for motor function. Now motor function, depending on the injury, if they have a decrease in motor function, it could be due to damage to the nerve, but it could also be due to damage to the tendons or to the musculature that's involved or necessary for that motor function. So if I ask someone to, say, squeeze my fingers, if I have a large laceration across my forearm, well, it's important to remember that those muscles in the forearm are actually responsible for flexion of my fingers. And so if I have some kind of damage to the musculature and to the tendons there, that might be the reason why I'm having motor impairment. It might not be due to nerve damage. So certainly muscles and tendons heal a lot better than nerves. Nerves typically, depending on the involvement, don't have as good of a prognosis for getting that motor function back. After we've after we've thoroughly assessed for neurovascular status and assessed the extent of the injury, we really want to limit the possibility of infection. And this is really where the wilderness aspect of this talk comes into play, because oftentimes when we're out in the wilderness, we're not super clean. Maybe we've been hiking, we've been sweating a lot, we've been kicking up a lot of dirt, and we've got a lot of dirt and other bacteria on our skin. Maybe we're in some water, a body of water that wasn't clean, such as a lake or a pond. So it's important to recognize that this management of infection and really preventing infection is super, super important. What we see is that bacterial growth actually is actually exponential, and it's usually right around the 6-hour mark after an injury that we see this rapid growth, this huge peak in bacterial growth. And so that 6-hour mark is really key when we consider the potential for these wounds to become infected. If we expect that it's going to be 6 hours or greater before we get this person in the hospital, it's very important that we take the necessary steps to prevent that type of infection. It's also just important to recognize that the earlier that we can use these methods to prevent infection, the better off this patient's going to be. So when we talk about preventing infection, probably the most important thing that we can do is what we call pressure irrigation. And so what that means is that we're forcefully expelling some kind of fluid, some kind of water into the injury, into the wound, to force all of the dirt and all the bacteria and all of that out of the wound. So it's simply not enough to take your hand and run it under a faucet. That's certainly irrigation, but it's not what we call pressure irrigation. So there have been some studies to demonstrate that you have to get right around 25 psi or so of water to really forcefully irrigate all that stuff out of a wound. And so again, you just really don't get that when you run a hand under some water or if you just take a bottle of water and dump it over the wound. So typically what we do when we do pressure irrigation, what we found to be very effective is to take a large syringe, say a 20, 30, maybe even a 50 cc syringe, so a very large syringe. You drop water and then you attach, you can use a needle, but oftentimes I like to use an angiocatheter, so something that we might use for starting an IV. I find that 18 gauge, and it's certainly supported in the literature, that an 18 gauge needle or angiocatheter creates a very good level of pressure for wound irrigation. So then what you're basically going to do is you're going to then what you're going to do after you have your syringe with the needle or the angiocatheter is you're then going to force that water into the wound to expel all of that nastiness. You can use what's called pressure lavage, which is basically where you're kind of have this pulsatile pressure, so the pressure is coming and going, and that has been shown to be very effective as well. Now when we talk about solutions for pressure irrigation, it's important to recognize that we actually don't need to use sterile saline or sterile water for pressure irrigation. It's been shown quite heavily in the literature and in the studies that if the water is good enough to drink, if it's potable, then it's certainly good enough for wound irrigation. So you can take that water out of your Nalgene that maybe you got out of a faucet. If it's good enough to drink, it's good enough to pressure irrigate with. Again, that's still going to be very effective in preventing wound infection down the road. So it doesn't have to be water that's treated with iodine, which is commonly what you see in the hospital setting. Now, with that being said, if you are out backpacking, certainly use whatever water treatment technique you would normally use before drinking the water, before you irrigate the wound. So maybe that's iodine tablets, maybe that's a filter device, maybe it's one of those UV SteriPens. Certainly anything that makes that water drinkable is going to make that an effective solution for irrigating the wound. We usually like to use at least 1 liter of water, the more the better. So anywhere up to 3 liters has been shown to be effective. So the 1 to 3 liter range for irrigating a wound has been shown to be effective. Any more than 3 liters, it's kind of a little excessive. But again, that also kind of depends on the extent of the wound. So something that's very large, a very large wound, is certainly going to require more irrigation water to very thoroughly clean it out. It's quite interesting. Wound irrigation in certain settings has actually been shown to be more beneficial than antibiotics in preventing in preventing infection of a wound. So again, I can't harp on the importance of wound irrigation enough. It's very important that you thoroughly irrigate out that wound before closing it or before dressing it to prevent that infection down the road. Now, after we've cleaned the wound and we've addressed that potential for infection, we can then dress the wound. Commonly, we like to use some kind of bulky dressing, so gauze pads or something along those lines, something that's absorbent, that's going to absorb any blood that might be present. That's going to be beneficial for us. So typically taking some kind of absorbent pads, placing it on the wound, and then wrapping it in some kind of gauze, say Curlex or something along those lines. That's going to be our typical way that we dress wounds. And then lastly, it's important to recognize that a lot of people like to take a look at the wound to see what's going on, especially when you hand off this patient to, say, an EMS provider. They're going to want to look underneath the bandaging to see the extent of the wound. But recognize that every time that you open up that dressing, you're simply exposing it to all those pathogens that are floating around outside in the world. So the less that you monitor the wound, the better. So generally speaking, if you're going to have someone for an extended period of time, simply leave that dressing there for 24, 48 hours before checking it. And at that point, you're checking it not just to look at the wound, but to replace the dressing and to replace it with a clean, fresh dressing. So don't get over anxious and start looking at the wound a lot. Again, that's going to increase that potential for infection down the road.